All right, well, let's get started. My name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan, and the topic of this evening's Learn and Share conference call is Sudden Unexpected Death in Epilepsy, or SUDEP. And we're very pleased to have with us Dr. Orrin Devinsky, who is an epileptologist at NYU Langone Comprehensive Epilepsy Center and a national expert on SUDEP and epilepsy research, and also Kellie Jankowski, who is Support and Community Program Coordinator at the SUDEP Institute, which is part of Epilepsy Foundation National Office. Welcome, both of you.
Thank you.
Great. And can each of you just please introduce yourself and share just a bit about your experience with this topic?
So my name is Orrin Devinsky. I am an epilepsy neurologist who cares for both children and adults at NYU, and have been a practicing epilepsy specialist for a bit over 25 years. And unfortunately, anyone in epilepsy becomes familiar with SUDEP through personal experience and having cared for a large number of people. I've unfortunately had a fair number of SUDEP cases, and in the last 10 years, it's been in a very important area of research for me to learn about and help better understand this so we can try to prevent it.
Great. Kellie?
My name is Kellie Jankowski, and as Russ said, I'm the Support and Community Program Coordinator through the SUDEP Institute. I became involved when, in 2006, we lost our 16-year-old daughter to SUDEP. So I've kind of made it a mission of mine to help bring awareness and raise money for research and whatever I can do to help. And I also became a grief counselor. And through my contacts at the Epilepsy Foundation, I became the Support and Community Program Coordinator.
Great. Thank you, Kellie. All right. So, Dr. Devinsky, now if you could tell us a little bit about SUDEP and what we know about the causes, what the risk factors are, and then also what can be done to reduce one's risk. So I'll just kind of hand the floor to you now.
Okay, thank you. So to begin with, I think it's important for people with epilepsy and their family members to understand that SUDEP is a very important cause of epilepsy-related mortality, but very sadly, it is not the only one. So many deaths among people with epilepsy occur from very prolonged seizures, status epilepticus. Some deaths, up to 10% of deaths of people with epilepsy occur from drowning. And I can tell you, someone who's 17 who likes to take a bath, who's been seizure-free for 3 years, unfortunately, has a single convulsion in the bathtub and can drown in a bathtub. So, sometimes people assume it's just SUDEP. Car accidents where people fall down a flight of stairs during a seizure. There are sadly many ways in which epilepsy contributes to premature mortality, including things like suicide, drug poisoning. People with epilepsy are at much greater risk of dying from pneumonia. So, just keep in mind, SUDEP will be what we focus on, but it is not the only reason. So overall, when studies have been done epidemiologically, and you look at young adults, people between ages, let's say 15 and 50, the risk of sudden death among people with epilepsy is about 25-fold greater than the general population. Now, how much of all the epilepsy-related deaths that I mentioned before, from drowning and car accidents and falls and pneumonia, which may all result from seizure activity, are due to SUDEP, and it really varies by the study. In some studies, SUDEP is 60% of epilepsy-related deaths, and in some studies it's less than 20%. And a lot of that has to do just the way we get data, and some of these data sets are from large population-based studies like all over Ohio. They look at everyone who is Medicaid, and those may not be as accurate as some of the really careful studies done in Scandinavian countries where they have access to everyone's medical records and can really track things very well. But the reality is mortality in epilepsy is definitely increased. So how do we define SUDEP? It is a sudden, unexpected death that is not a result of trauma, it's not a result of an overdose or poisoning from some cause, like cocaine intoxication, and to be definite, there should be an autopsy which reveals no other cause of death, like a heart attack or a pulmonary embolism or cancer. It's probable SUDEP if a person dies, and the classic setting I'll get to is where they die in sleep, for example. A seizure causes them to go face down is what often occurs, but the family or the medical examiner coroner decides not to do an autopsy, then we can't be sure they didn't have a pulmonary embolism or a heart attack. And it's possible if there's another cause of death that occurs. So you get someone who's 70, who's had some heart disease, who's had uncontrolled epilepsy, and they die suddenly. It's not witnessed. Could have been the heart disease in a 70-year-old, could have been SUDEP. We just have to say we're not sure, and it's a possible SUDEP. The risk of SUDEP goes up as you age out of the pediatric population. At least that's been the standard teaching. So in general, the incidence of SUDEP in young children under age 12 is very, very low. The numbers, in epidemiologic terms, is in the rate of something like, 1 to 3 per 10,000 patient years. I'm not a big fan of those numbers because I don't think we intuitively understand that. But another way to do it is if you have a child with mild epilepsy that's well controlled or rare mild seizures, the risk that child will die from SUDEP, over the course of a decade, well under 1%. Whereas if you start getting into populations, where you're an adult with epilepsy, then the risk of dying from SUDEP is about 1% over a decade. It's not an enormous number. It's not, terrible number, but it's a whole lot higher than the general population. And when you start getting into the group of people who have treatment-resistant epilepsy, who go to an epilepsy center and think about having surgery, the risk of SUDEP over a 10-year period gets as high as about 5. And in some populations, those who have had epilepsy surgery and keep having seizures, it may get up as high as like 8 or 9% per decade. So it gives you the range from young children who are well-controlled, have extremely low rates. As you get to the adult population in the general community, it's like 1% per decade, and then in those with more severe epilepsies, it's 5% or even higher. So what are the risk factors for SUDEP? So the most clear and black and white risk factor for someone developing SUDEP would be uncontrolled generalized tonic-clonic seizures. So the fact that someone has had a generalized tonic-clonic seizure in the last 6 months or the last year, the fact that there have been more than one, those will all increase the risk. Seizures that occur in sleep also increase the risk. People who have epilepsy due to a known cause, like a stroke or head trauma or encephalitis or meningitis, are going to be at higher risk. People who miss medications who decide not to take medications, and then those who have early age of epilepsy onset with long duration of epilepsy. So someone who had seizures beginning at age 5, at the time at which they're 25, their risk of SUDEP is going to go up. And in some studies, males and those with intellectual disability have had higher rates of SUDEP. What are factors that decrease SUDEP rate? Seizure freedom is by far and away the biggest one. Being observed during sleep is another relatively protective factor in some studies. And the recent addition of an anti-epileptic drug, we know from some large double-blind studies, when you pool all the drug studies from the last 15 years, if you have, let's say, uncontrolled epilepsy, and you enter a drug study and you're on, let's just say, carbamazepine and levetiracetam, Keppra and Tegretol, and you continue to have seizures, and you enter a drug study, and I put you in the arm where you get a new drug that works, and I compare you to those who get put on placebo for 3 months, when you take all of those studies and add them together, there is a dramatically higher risk of SUDEP in the placebo group during that 3-month period. Now, it's not reasonable that we keep adding new drugs every 3 months to someone's regimen, but it just goes to show that degree of added seizure control from an additional drug for 3 months dramatically lowers SUDEP rate. And that can be at least a 10-fold reduction in SUDEP rate during that 3-month period. So again, it speaks to the fact that seizure control is the driving factor in reducing SUDEP rate, and lack of seizure control, especially for grand mal or tonic-clonic seizures, will increase the SUDEP rate. Now, what do we know? Well, the standard or classic circumstances for seizures are that they occur in sleep in about 60% of cases, and that they're not witnessed in about 85 to 90% of cases. And what that, tells us, and I think, this is a pretty consistent story, is that unfortunately, kids who are sleeping alone or young adolescents, adults living with their families, living in their own bedroom, and more often living in their own apartment or in an apartment where they have their own room and have a roommate, if they're not married or with a partner at night, if they have a seizure in sleep and the seizure causes them to roll over and they're in a face-down position, that's going to dramatically increase their risk of SUDEP. And I'll get into some of those mechanisms, but people who have nighttime seizures have about a 3-fold elevated risk of sleep-related SUDEP compared to people who don't have a history of seizures during sleep. So that's one of the factors that we look for. So what actually causes SUDEP? And to be candid, we don't fully know. What we believe happens in the large majority of cases is that a seizure occurs right before death. So in the studies that have asked family members or, gone through cases from medical examiners or offices, in those cases where the SUDEP was witnessed, which is a small minority, as I said, 10 or 15%, but of those who were witnessed, 90% of the cases had a seizure right before the SUDEP occurred, and in most of those cases, the family member or witness observed difficulty breathing. We also have a very unique set of data from Philippe Rouvelin in France and people around the world where SUDEPs actually occurred in the hospital in an epilepsy monitoring unit. So here are cases where we bring people into the hospital, often to consider possibly doing surgery. And when they come in, we lower meds to record a seizure, so we can do it within several days or a week. And unfortunately, in some cases, a patient had a seizure, and in almost all of these cases, a nurse or physician did not get there soon enough. The monitoring system either wasn't in place or had a failure. We're all, humans, and this happens thousands and thousands of times across the world. So there have been 11 cases recorded. All 11 followed tonic-clonic or grand mal seizures. And the mechanisms appear to be 3 main mechanisms. After a seizure, the brain shuts down, and people are essentially in a coma right after a grand mal seizure. You could take your knuckles and put it in their sternum or chest bone, and people won't respond after a seizure. Their arousal is dramatically impaired, and if you record their EEG, it often goes flat after a seizure, as much of the brain is essentially in the off position. In addition, there can be respiratory issues, both because the brain is in the off position. As you may know from experiments in high school, you can take a frog and piff it at the neck, and the heart will continue to breathe, but the frog will stop breathing. And that's true for mammals and humans as well. We need our brain to turn the breathing centers on in the bottom of the brain and to turn the lungs into a breathing machine. So if the brain's in the off position, you don't breathe. In addition, in some cases during seizures, there can be other changes like fluid accumulation in the lungs and some other problems with breathing. And then there can also be problems with the functioning of the heart and the cardiac system, such as low blood pressure, all of which, especially when these 3 things occur probably together in some cases, and the patient is unfortunately in a face-down position, it's just a catastrophic problem, and by the time the brain may wake up to some degree, there may already be a cascade of problems from the lack of breathing, heart arrhythmias, or blood pressure problems that may be non-recoverable. And the cerebral shutdown has been studied by my colleague Sam Latu at Case Western, And individuals who he monitored in his epilepsy monitoring unit who had very prolonged periods of this EEG suppression after a seizure turned out to be at much higher risk for SUDEP. However, we have to keep in mind that not all tonic-clonic seizures are the same. And so Dr. Rivlin did a study where he looked at people who had generalized convulsive seizures, and it turned out those in which both upper extremities and or lower extremities, arms and legs, were stiff, had a 66-fold greater chance of having the EEG suppression after the seizure. In addition, if patients were attended to rapidly by the nursing staff and awakened and potentially suctioned to get secretions out and given oxygen, the EEG suppression was much shorter as well. And as makes sense, if the seizures occurred in sleep, then the chance of having this EEG suppression is greater. So again, we keep getting more and more information that's converging on the same set of risk factors. Nighttime seizures, lack of someone getting to the patient quickly will all increase the risk of SUDEP. And so there have been a lot of animal models looking at this, for example, in Dravet syndrome, in several of the childhood severe epilepsies like Dravet syndrome and DUP15Q and SCN2A and SCN8A, a variety of different gene mutations that cause bad epilepsy. We can show in animal models that there are also higher rates of SUDEP and have studied them. So one of the biggest problems with SUDEP is that the medical community, myself included for much of my life, has done a terrible job of educating both other physicians and family members. So I was a resident at New York Hospital Cornell Medical Center with some of the best and most famous neurologists in the country 30 years ago, and I was never taught that seizures harm the brain. I was never taught that seizures can be lethal. And yet William Spratling, who was one of the pioneers, American epileptologists, wrote a book in 1904 and wrote seizures destroy life suddenly and without warning through a single brief attack, and does so in 3 to 4% of all who suffer from it. So we need to be better as a community, and this has been studied, and it turns out, we think of the big killers among neurologic disorders like dementia, Alzheimer's disease, and stroke, and when you turn it into patient life years that are lost, so a disorder like SIDS that takes the life of babies under age 1 may take away 75 life years from that baby. Because SUDEP tends to be a disorder of young people at peaks between ages 15 and 45, it takes away a lot of life years. So when you look at the number of life years lost to neurologic disorders, stroke is number 1, but SUDEP is number 2 and is more than 50%. And all the other neurologic disorders like Lou Gehrig's disease or ALS, multiple sclerosis, Alzheimer's, Parkinson's are all way behind. So unfortunately, this has not been recognized by the medical community to the degree it should be. And because of that, neurologists have not been good about educating patients. There's a recent study, just to put in parenthetically, which came from Sweden, which is based on really good data. And it looks like in the Swedish population, where they did exhaustive search of every person who died in the country over a 1-year period and matched it to really good medical records, it turned out the SUDEP rate in individuals under age 16 is not that much different. It actually was about 1 per 1,000 patient years, or about 1% per decade. So, it may turn out we have to modify what we've been teaching people. In the same way, an organization that I helped create and lead, the North American SUDEP Registry, has identified 3 children, and this will be published in probably the next month or so, children with benign Rolandic epilepsy, or benign epilepsy of childhood with centrotemporal spikes, which has always been considered a completely benign disorder. Everyone outgrows it and lives happily ever after. And we recently identified 3 cases among our first 200 cases of SUDEP that we identified. So I think we need to start thinking differently about who's at risk. These were mild cases that neurologists typically say, don't worry, none of these kids were on medication, because it was felt that the medicines are worse than the seizures. And unfortunately for these 3 children, that was not Correct. So, we as a medical community, I would say, have failed, and one reason I don't think the SUDEP rates have come down at all. We haven't educated our colleagues, we haven't educated our patients, we haven't collaborated with medical examiners, and we haven't really spent time on focusing on how to reduce the SUDEP rate. So we've done some surveys about how frequently doctors discuss SUDEP with patients, and among neurologists, 12% never talk about it, and only 21% talk about it with more than half of their patients. So it's kind of a failing grade, I would say, of American and Canadian neurologists who we surveyed. We also surveyed through epilepsy.com about 1,400 people with epilepsy, about 600 caregivers. We also did some of that in our clinic as well. And the bottom line is of people who have epilepsy or caregivers of people with epilepsy, of those who knew about it, the vast majority learn about it from the internet, and very few learn about it from their neurologist or epileptologist. So again, it's really something we have not done a great job of educating people about. And I think it's important because I think if many people understood they could die from one seizure, missing a single dose of medication, if someone takes medicines twice a day and misses their nighttime dose, and this has happened to my patients, they have a single tonic-clonic seizure at 6 a.m., they can die from it. So unlike high blood pressure, where if you take 80% of your meds, you're basically in pretty good shape for blood pressure control. With epilepsy, you miss one dose of medication, it can be deadly. Not that that's a likely occurrence, but it certainly can happen. And, why does education matter? Well, let's think about it in relative terms. SUDEP kills about as many Americans as fires kill. It's about 3,100 people per year. SIDS kills about 2,100, actually closer to 1,600 now with some of the preventive strategies, children per year. So let's think about that. SUDEP kills as many people as fire and kills about twice as many people as SIDS. And yet I would say there's almost no person with a good high school education in the United States who isn't aware that fires can be deadly. And I would say there's almost no parent, who has a good education who isn't aware that SIDS is a potential issue. So how can it be that among people with epilepsy, which is about 1% of the population in the United States, we haven't done a really good job educating them about SUDEP and the importance of seizure control? So again, part of this is how things are phrased, and this has been studied. So if you were to say to a high school student at driver's ed that wearing a seatbelt is important because 1 out of every 3.5 million person trips in a car is fatal, and that number doesn't mean a lot to a person. And when you say it's 1 in 3.5 million, it's kind of like winning the lottery, and people don't relate to that. But if you were to rephrase that and say over 50 years, you have a 1% chance of dying and a 33% chance of being in an accident that leads to a permanent disability, that does change behavior. Because 1% chance of dying and 33% chance of something horrible is something people can relate to. So again, if you're counseling or want to educate a 17-year-old who thinks they're invincible, even if they're well controlled, why is it important not to miss meds? Well, it's about 1% risk of dying per decade. And if they have poorly controlled epilepsy, it's 5% or higher. And unfortunately, another thing that has not been well publicized but is out there is that SUDEP rates are much, much higher in lower socioeconomic areas, probably because they get less access to care, get less access to higher level interventions like epilepsy surgery, which can be curative, and unfortunately because of that, die more frequently. What are some of the strategies to prevent SUDEP? Well, there's nothing proven other than better seizure control, but there are several alarms that people are probably aware of, some things that could be put under a mattress to detect movement. There are now several watches that are available that detect either movement, which would indicate a seizure and can alarm a family member in another room, A new device called the Embrace Empatica Watch came out that looks at both movement and electrodermal activity, which is a measure of sweating and sympathetic nervous system activity, but it changes during seizures. It's kind of the old lie detector test, but it's been shown to become abnormal during a seizure. So there are several devices that are out there that could be used. We cannot prove that they will prevent SUDEP from occurring, but I believe in my heart that it is likely that if someone like a roommate or a family member could be alarmed and could get to that person within a minute or two, it is likely that some cases of SUDEP could be prevented. I do not think all cases could be prevented, but probably some could be prevented. By the same token, to have someone wear a watch and have no one be around, if a 25-year-old adult is living in downtown Manhattan and the alarm goes to their parents who are 2 miles away in northern Manhattan, there's not much the parents can do other than call, the police or EMS, and the chances that they'll get there in 2 minutes is close to zero. So it's ideal to have an alarm if someone is either in the apartment or the apartment next door. There are some other things that have been looked at, like anti-suffocation pillows. They're theoretically maybe beneficial and make sense, but they've never really been adequately studied or proven to be terribly effective. So with that, I will also leave on a positive note. The NINDS did fund a large Center for SUDEP Research with Sam Latu on the clinical side and Jeff Nobles on the basic science side are leading. We're involved with it. I think at least 10 or so sites around the world, including London, and many U.S. sites are involved in this Center Without Walls to help understand and combat SUDEP. But it's still in the early going, and many studies are ongoing, and many of the people involved in the center and elsewhere are also involved in many other SUDEP-related research projects, one of which I mentioned briefly, the North American SUDEP Registry that I've been involved with, and we now have well over 200 cases. And if anyone ever knows of a patient who unfortunately had a SUDEP, I would, be happy to speak to the family and discuss with them being involved with the registry. It doesn't require anything other than sharing information, and we'll do all the legwork of tracking down any of the medical records and interacting with the medical examiner. We can get the most information when we learn of cases like I did today from one of my colleagues. A man died after a seizure in a hospital, but we were able to get both blood and a brain donation from that person, and now that tissue can be used by potentially tens or even 100 researchers to help study SUDEP and look at what we can do to help combat it. And we're looking at gene changes that may predispose people with SUDEP, and there have been abnormalities that have been identified. Nothing we can do right now on a screening basis, but we hope within a few years we may start to get close to there. So I think in concluding, where we want to be is to understand this better. We have a good idea of the mechanisms, but we far from fully understand them. We as a medical community, and I think a lay community like Epilepsy Foundation, need to do a better job of educating family members, patients, and healthcare workers about the possibility of SUDEP and other causes of epilepsy-related mortality. Think about devices that may predict or detect seizures, can alarm caregivers, and how we could stimulate arousal and breathing after a seizure, and then just work more collaboratively as an epilepsy community of scientists, of doctors, of patients and families, of lay organizations, of how we can get together and solve this problem. Thank you.
Okay, thank you, Dr. Devinsky. I have a few questions for Kellie now. In talking with families who've lost a loved one to SUDEP, what are some common complaints and regrets that you hear in terms of what doctors did or did not tell them about SUDEP?
The biggest complaint is actually, and Dr. Devinsky hit on it, was not being told by the doctors about SUDEP and knowing that there are risk factors out there, such as missing medications, or not knowing and being able to maybe put some of those monitors, as Dr. Devinsky mentioned, the heart monitors, the pillow, even dogs nowadays, they have the seizure response dogs. That's been the biggest complaint of why were they not told about SUDEP and that it was even a possibility. I know, just speaking for myself, we were not told ourselves either, and I know that our daughter had been off of her medication for a year. She had been seizure-free for 3 years and met the qualifications to come off the meds. And maybe if we had been told about SUDEP, maybe we would have made a different choice on, stopping the medications. And then for those that knew about SUDEP, it was more worrisome for them, and it still happened. But at least they were aware, and they were thankful that they were aware of that.
Right. So this is, the concern and probably the reason that neurologists haven't spoken with families about it as much as they should have in the past is they didn't want to cause, unnecessary worry or anxiety. So now that neurologists are talking about it, how and when you talk to patients and families, how do you counsel them in such a way so that a healthy knowledge of risk does not then devolve into harmful emotions and behaviors like constant worry or fear or even depression or overprotection by family members, not letting the family member with epilepsy live their life? How do you handle that delicate balance?
Dr. Devinsky, how do you explain it to the families?
I try to do it in a reassuring way to discuss SUDEP, that it is a low risk, but that it is a risk. And, the big challenge is, the reality of life is that, people hear things and we can all deny it. Look how many people in the United States are obese, and look how many people smoke cigarettes and, do things that are, negative, have clear and well-advertised negative health consequences. So I think, we can be honest and explain it, and I think, many people hear it, and I think if it does cause a little bit of fear, that's probably good. Number one, it's the truth, so I think we ethically need to share the truth with our patients. Because the risk is low for any individual, even those with treatment-resistant epilepsy. It's 5% per decade. It's not a number I would want myself and want for any of my patients, but it's not a horrific number. And you're right, some people are very anxious. Epilepsy has higher rates of anxiety. And so you just have to come up with strategies and try to empower people to take more control and take steps to reduce the risk, which is all we can do. What's difficult is you say this to a 17-year-old as they're going off to college, that if they drink too much, they get sleep deprived, they miss their medications, they can have a seizure. And the reality is they all do most of those things over the course of their freshman year of college, no matter how many times I warn them not to do it, because they're freshmen at college, and that's part of being a freshman is taking risks and being part of the peer group, and it can be a very dangerous time.
Well, I just think that people are wanting to hear about all the risk factors that they're dealing with, cancer, and have all that knowledge, or diabetes, or whatever it may be. I think the same is with epilepsy. You need to have all that information available of things that can and cannot happen. I believe education is power. Knowledge is power. You need to know all the risk factors, whether it's good or it's bad.
Right.
Yep, I agree.
So, Kellie, for families who've lost a loved one to SUDEP, it's common to experience a wide range of emotions, including guilt, regret, sadness, anger. Families may also feel compelled to assign blame or to try and find answers or to try and prevent this from happening to others. Can you talk about the grieving process and some different coping skills that can help?
I believe everybody grieves differently. That's one thing that I have found. And the one thing everybody needs to remember is that when everybody's grief is different, especially when you're dealing in a household, I'll use myself as an example. My stage of grief, may have been in the anger stage, as my husband, may have been in the guilt stage, and our other daughters were in different stages, and remembering to be kind to one another, and that you're all dealing with the grief. I think it's important to get involved in a support group. I was lucky enough that a church member had dealt with grief from losing a child due to cancer and invited me to her support group. And that was my best way to recovery, and trying to learn different coping skills and knowing what works for me may not work for somebody else. And then I was also blessed to get involved with the Epilepsy Foundation of Michigan, who helped me find ways of helping to bring awareness and realizing that this needs to be brought to the forefront. I've had other people that have gotten involved in raising money for the foundation and research, getting involved with NASR, participating in the national walks and local walks. Some have turned to different grieving books. I just had a gentleman who lost a son who makes sure that he goes to Congress and tries to bring awareness to this. We also, the SUDEP Institute has an online site. It's specifically geared towards bereavement. Anybody that's lost someone due to epilepsy does not have to be specifically SUDEP, but a form of epilepsy. And friends and family are a good resource for coping. Those that love you know you best and know what you need. And just think talking about it and finding these different avenues is a blessing.
Right. Okay. And just in closing, before we open it up for questions, Dr. Devinsky, can you talk about the guidelines as to when patients with epilepsy should seek specialty care, should see an epileptologist at a comprehensive epilepsy center? Because certainly we run across a lot of people who've been with a general neurologist or even a primary care physician for years and have tried many different medications and continue to have seizures and were never referred. So can you talk about the standards of when people should seek specialty care?
Yes, in my own view is that if you've been on 2 or more medications, or you are experiencing ongoing seizures or side effects, then you should seek specialty care at an epilepsy center. And I think, the advantages are manyfold. The biggest is just the expertise of physicians, nurse practitioners, nurses, dietitians, social workers who are familiar with epilepsy, who can, I've had cases that the wrong type of epilepsy was diagnosed, or someone was treating someone with anti-epilepsy drugs and they'd never had epilepsy. I mean, it could go on forever. But I think it's critical, if you've been treated and you're either on your second drug or you're continuing to have side effects or seizures that are bothersome, that's the time to seek specialty care.
Right, and certainly one of the things you may be evaluated for would be epilepsy surgery, and while it's understandable and reasonable to consider the risks of surgery, why is it also important to consider the risks of not having surgery? And is that something that is typically conveyed by epileptologists when they're talking to patients about surgery?
It is. I think the issue of surgery is a hard one, and I think it just speaks to the way human beings look at risk. And I think, again, this goes to neurologists as well who aren't as familiar with epilepsy. But my favorite example, because I bring this up when I talk to people about surgery, who I think are good candidates and who are hesitant, when risk is encapsulated in a short period of time, people, I think understandably, react negatively to that kind of risk. So surgery is encapsulating all the risk into a multi-hour procedure. And Whereas living with epilepsy for 10 years, you can be pretty darn sure tomorrow will be very similar to today, and the day after that will be very similar to yesterday, et cetera. But over 10 years, you can't be so sure that things will at all be similar. Memory may well be worse. Mood may be more depressed. The amount of medication you may be on may be greater, and you may risk a 5% chance of dying from SUDEP. So in the last 25 years at NYU, we've had probably 2 deaths from surgery out of well over 2,000 people, and we've probably had about 200 SUDEPs. So if you think about the relative risk, and that's, we've had more people die waiting for surgery by threefold than the number of people who have died from a surgery. So the point is, waiting is much more dangerous than the surgery. And my, paradigm example of that is after the World Trade Centers were destroyed by terrorists and 2,000 Americans lost their lives in the World Trade Centers, many families, including my own, my wife and I were scheduled to fly with our 2 young girls at the time to Colorado to go skiing, and my wife said, I'm not getting on an airplane. We canceled our trip in December, and we ended up driving up to Vermont to go skiing. Well, a very bright German psychologist in the mid-2000s, 2008 or something, looked at the motor vehicle deaths in the United States from September 11, 2001 to September 10, 2002, and compared it to each year in the preceding decade. And there were in excess of at least 2,000 deaths in the year after 9/11 from people driving like we did. So we did, we went from the frying pan into the fire. We decided driving was safer than flying, and we were wrong, and we were stupid. We made an emotional decision that seemed safe. It seemed like getting behind a wheel and driving to Vermont was a safe thing to do, whereas after 9/11, getting on an airplane was a very dangerous thing to do. And because we did that, and because our national leaders didn't counsel us, as had been done in London, for example, after a subway bombing, when the Prime Minister got up and said, I'm taking the tubes the next day, and it's never been safer, we led 2,000 Americans. We killed as many people as died in the terrorist attacks, and that's what happens, I think, many times when people are truly good candidates for surgery and they're just scared. I understand it. I wouldn't want surgery on any part of my body, most importantly on my brain, but I definitely would if I had treatment-resistant epilepsy and was a good candidate.
Okay, great points. All right, I think we'll go ahead and open it up for questions now. Okay, who would like to get us started with a question?
I have a question.
Go ahead.
Oh, sorry. Thank you very much for the presentation. It was really good. Can you comment on the incidence, if it's known, of SUDEP in simple partial seizures? If someone only has simple partial seizures, have there been any cases reported?
So no, I think the answer is if the seizures are all simple partial, then to the best of our knowledge, the SUDEP rate should be very, very, very close to 0. I'm not aware of any case documented. There are a few SUDEPs that have been documented without seizures, where people were on an EEG and were being recorded and they died suddenly, and there's a sudden death in epilepsy. In addition, there are unfortunately people who have had simple partial seizures for 3 years, and that's all they've had, and then all of a sudden they're sleep deprived or had too much to drink the night before and have a tonic-clonic seizure. So that's the only caveat I would put in there, is that just because someone's only had simple partial seizures for 3 years, it doesn't guarantee that they can't have a bigger seizure in the future.
Okay, thank you.
Okay, another question?
I have a question.
Yep, go ahead.
You mentioned that a lot of the neurologists, they don't tell the patient about this. I was wondering, doesn't neurologists have to go, to take updated classes or something on, because there's always new information on all kinds of sicknesses, and I was wondering if they have to go back and take updated classes Because I never heard of this either, actually.
So neurologists and all doctors typically, depends on the state law, but they often require some continuing medical education. The problem is that, number one, not all states require it. Some people, can go to Hawaii and go to a meeting and check in and not do anything. But realistically, they can take courses on whatever they want. So if you're a neurologist, you could get all your CME doing migraine courses. And you could do 100 hours of epilepsy courses, not that anybody does that who's a general neurologist, and never touch on SUDEP. You might learn about new drugs. You might learn about EG diagnosis. So the problem is most of us, including myself, I never learned about this when I was a resident 30 years ago. I think it's now in the literature that hopefully neurologists who read the main journals see it occasionally. But, part of it is, people say, well, I haven't seen this, so I don't need to worry about it. And that's a mistake because they've almost all seen it. They just don't know they've seen it.
Right.
Okay. Does anyone else have a question?
Well, I would like to say, because I know I actually I'm having seizures since I was 2 years old. And my seizures are uncontrollable. Yes, not here, brain surgery, not that's being that's Vegas nerve stimulator. I was just wondering about things right there. I did thank you for your comments.
Okay. Yeah, so in cases where someone has already had surgery, has already had a VNS, has explored pretty much all treatment options and is still having seizures, are there other options? Should people reconsider, being evaluated for surgery again if the first surgery wasn't successful?
Yes, I think the answer is yes, and I think hopefully you're being followed. If you're such, unfortunately you've been a difficult to control case, but been seen at an epilepsy center, and I would go back there or potentially consider another center just to get another opinion as to what might be done in your case, because it is worthwhile. I think you all need to, if someone's been following you for 10 years, they sometimes helpful to someone else look at your case with a fresh view and what other options, either medically or surgically, or even diet in some cases, could be considered.
All right, great. Okay, other questions?
I have a question.
Go ahead.
I want you to know that you're talking to a somewhat irrational mother here.
Okay.
My college age. Can you hear me?
Yep.
Yeah.
Okay, my college-age daughter wants to take her neurologist up on weaning off her meds this summer, which I don't understand, by the way. She's been seizure-free for about 4 years. So I'm trying to mentally prepare myself for this undertaking. Do you have any advice for me?
No, I think it's, obviously these decisions are, very much dependent on the individual case, and if she's been seizure-free and her EEGs look good, and she's a young adult, it probably makes a lot of sense to wean her off medications. And there's, there are risks to taking medicines for, the next 60 years of her life if she doesn't need it, and there are risks to coming off medications. Having said that, I think it's just something to maybe meet with her neurologist. Driving is an issue. God forbid she broke through. So, there's issues to discuss, but the good news is if the neurologist recommends it and thinks it's a good idea, more than 90% of the time or so, it turns out to be a very good idea. And in the infrequent time that a seizure does break through, usually it's a mild or moderate seizure, or it occurs in a safe setting around other people, and the person recovers fine and gets put back on medications. Obviously, tomorrow's not promised to anybody, and
right.
Different numbers. The risk of everyone in America, just averaged out, is about 1 in 7,000 per year of dying in a car accident. So, we all face different risks as we get older. Obviously, we all face a lot more risks.
Well, that's exactly what I needed to hear. Thank you.
Okay, great. We have a few more minutes left. Any other questions?
Ross, Greg.
Yeah, go ahead.
If you live alone, it's not wise either, is it? If you have seizures.
Yeah, I mean, ideally, I mean, I don't think a lot of people have a choice. But I think if there is a roommate, or if you can have an apartment with someone else in another room who's willing to be alarmed, and God forbid, especially if someone has a history of nighttime seizures, you know, in the best of all worlds, yeah, it's probably not a great thing to be sleeping alone. But I think, unfortunately, not everyone has that luxury to choose. If you're single and you're 40 and you're not married, and, you know, your only option that you know about may be living alone, and it does pose some risk.
I got complex partial is what it is.
So in relation to when you mentioned the various alarm systems, what if a family member is alerted to a seizure, a nocturnal seizure, what would you recommend they do in response to arouse the person, or somehow reduce the risk of SUDEP if they're able to get
there? So I think the single most important thing is, you know, especially if the person is face down with their head in the pillow, you know, just basic common sense, roll them on their side. Yep. Their head, make sure their airway, both their nose and their mouth, is clear. Unfortunately, some people vomit with seizures, and that may increase the risk. You know, anything like that, just, you know, as best as you can, clear it away with, you know, with a sheet or something like that that's nearby. And then just support the person. I think if they're unconscious, once you've rolled them on the side, and make sure their airway is clear, you know, just kind of gently call their name and gently stimulate them, maybe rocking or, you know, shaking them gently, not vigorously and not to scare them, but just, you know, Bob, are you okay? Bob, can you wake up? And just stimulate them in that kind of way. But often I think just kind of rolling them over and calling their name and stimulating them to some degree, you know, probably can be life-saving in some cases. And that's why, you know, so many SUDEPs, 90% occur unwitnessed because no one is around. And if someone were around, then they would have done just basic first aid that you don't even need to be trained in, and that's probably life-saving in some cases.
And things like having you know, an automated defibrillator in the house, would that be too much, or would that even help if someone went to that extent, or what are your thoughts on that?
I don't think there's, you know, my own thoughts are there's no evidence. You know, when those 11 cases that we recorded in the epilepsy units, a cardiac arrhythmia was never the primary issue, so I don't even think, you know, I think that would be an extremely rare event that would be helpful, so I don't think it makes sense.
Right. Okay, well, I think we'll wrap it up, and I just really want to thank Dr. Devinsky and Kellie for your your input and your thoughts on this, and it's a really important issue, and I'm glad we're a part of raising awareness, and I appreciate all of your time and your sharing of your experience on this. And thank you, everyone, for joining us tonight.
Thank you very much.
Okay, take care. My pleasure. Thank you.